Hey, happy Tuesday, everyone. Welcome, good morning, good afternoon, good evening, wherever you are, and thanks for joining us here today. Austin and I are here to, help solve a case, and we have an amazing case presenter today. Amit, do you mind just telling us a little bit about yourself?
Okay, thank you very much for introducing me and having me in this VMR. I'm really excited. Okay, so my name is Amit Shrestha. I'm from Nepal. Currently in Kathmandu, and Nepal is, to give a brief introduction about my country, it's famous for the highest mountain peak in the world, the Mount Everest. So I am from the country of the mountains. And yes, I am practicing pediatrics in as a medical officer, an international Friends of Children Hospital, and I'm applying for the Math Cycle 2025 in for pediatrics. So yeah, that's a little bit about me, my education, and my geographical background. A little bit, I just love to hear the music whenever I'm free, just simple classical or the piano music. Instrumental music is the one that I prefer mostly. So yes, that's a little bit about me. Thank you very much for having me in this amazing team. Thank you very much for allowing me to present. Thank you.
Thank you so much for taking the time. And do you have a favorite composer when you listen to classical music?
I basically go to for like Mozart or Beethoven, mostly Mozart. Yes.
Wow, that's amazing. I'm a
Uh,
Chopin fan myself, but each you know.
okay.
But yeah, I think Heman's going to be helping us out with the scribing today, and Ibrahim is going to be doing the teaching points. So I think whenever you're ready, Ibrahim, go ahead, share the screen, and we can get started. And Austin, you want to tackle the first aliquot, or you want me to do it?
No, good. You go first, and I'm just hoping the patient is not like 5 years old, so that we
Yeah,
can successfully solve the case.
me too. Okay, Amit, whenever you're ready.
I am ready. Okay. Should I start? Okay, good to get that. Okay, so this was one of the case that I that me and my attending encountered in this in ER. So the patient is 12 years old male, and he had no any kind of comorbidities previously, and he presented us in the ER with basically two chief complaints. Number one, the lower back pain and difficulty in walking. The lower back pain was present for the past 14 days, and the patient was having difficulty to ambulate for the past 7 days. So this was the initial presentation, and for this presentation, we suggested some physiotherapy and some pain medications and discharged the patient, and the patient was doing pretty good. But 3 days later, what happened was the patient returned back with more severe back pain. The pain scoring was about like 8 out of 10, and this time the patient was morbidly bedridden. He was unable to ambulate at all. And the patient this time he also had dysphagia. He was unable to take any kind of solid or liquid foods or fluid, so, and also had a slurred of speech. And along with that, the patient also complained of the constipation. However, he had normal bladder habits. So this was the presentation this time. And to just give a clue to everyone here, we ruled out every negative history for this patient, and there was no any history of upper respiratory tract infections or GI infections. And also the patient didn't have a headache or behavioral changes or a loss of consciousness, abnormal body movements, vision issues, or facial deviations, or abnormal weaknesses, no rash, no joint or no joint pain or the swelling, neither any kind sort of bleeding, nor head trauma or animal bites. So this was the kind of the presentation that patient presented with.
Okay, is that the end of the first aliquot there, Amit? I hope so.
Yes, it is.
Okay, amazing. Thanks so much. I'll sort of, I guess, full disclosure, I'm not a pediatrician. So the last time I saw a 12-year-old patient was in medical school. So I'll probably be a little bit rusty there, but I'll just sort of act like the patient is 18 and sort of build my way from there.
Okay.
So we have a very rich history here, and I really appreciate the time course that Amit has laid out. And so 12-year-old, for the most part, young patients in general don't really present unless something is really wrong. And I feel like we're getting that flavor here as well. And everything starts with low back pain that's been more subacute. And, at least I remember listening to a discussion by Gurpreet once, and it sounds like, whereas an adult, we worry a lot about chest pain, and kids, chest pain is pretty benign. And for adults, back pain is typically pretty benign, and for kids, it can typically be a red flag symptoms. Just for some of the sort of associated pathologies with that. So in my adult mind, I'm sort of translating lower back pain oftentimes into a musculoskeletal issue. But here, because of the patient's age, my sort of red flags go up. Why that is, it's hard for me to explain since I'm not a pediatrician and I don't have the reps with that. But it is something that is concerning. And I think the progression here over the 2 weeks for the patient is completely normal, walking around, doing things, and is now essentially bedbound, is very, very concerning, potentially more sinister and potentially something more neurologic. And so I think the initial management conservatively seems pretty reasonable, but now that we have progression, we need to dive in a little bit more. And the back pain, whether that's referred for something into retroperitoneum or something that's in the spinal cord itself, or is a manifestation of a systemic illness, I guess we'll have to get some more information to find that out. And this isn't just a case of back pain, however. This has now progressed to include some dysphagia in poor intake and slurred speech. And I just think of all the neuro VMRs we had and how we might localize deletion here. And in the combination of what seems to be no lower extremity weakness, no clear sensory changes at this time, but hopefully we'll get that information later. Is this something that's in the spinal cord? Is this something that's in the brain itself? Or is this something that's in the peripheral nerves? And the more we work our way up from the legs all the way up to dysphagia, probably the spinal cord itself is a little bit unlikely if we're going to, try to be parsimonious with the diagnosis and thinking about more of the peripheral nerves or something in the primary CNS or multiple concurrent lesions is something that we'll have to consider. And the constipation in and of itself as well. I'm not sure if the patient has history of constipation. It sounds like not, but that would also potentially speak to maybe a spinal cord pathology, but I think it's a little bit unclear. And then, we had a very extensive negative review of systems overall. I didn't see, and I may have just missed it, whether the patient was having fevers or weight loss or other signs of systemic illness, but no signs of recent illnesses, which sometimes can trigger neurologic phenomenon. No evidence of seizures or rash or joint pains and whatnot. But, honestly, I'm sort of breaking down each symptom separately, seeing where I might be able to localize the lesion, and then trying to make diagnostic progress from there. But I think the subacute progressive nature is certainly very concerning for an underlying sort of unifying disease, but it's hard for me to make too much additional progress from there. But, we can layer in whatever past history meds and family history might be relevant here, or, to confirm where the patient is whether they live in Nepal or if they have any other risk factors. But, to me, this seems like a more subacute progressive neurologic syndrome, and we'll just have to sort of dive into that a little bit further and hopefully localize the lesion and then do diagnostics both on our imaging and exam and labs to kind of go from there. But Austin, can you layer in on that? So save me here.
No, man, I think that was brilliant. Like I'm not a pediatrician either, and I think the way you translated the back pain is more of an uncommon presentation in a younger person is really, really powerful. And so I think where I can maybe just add just a tiny bit is that the pain aspect of this. And so we talk about, as you mentioned, in pain, we see low back pain all the time. I guess someone just 20 minutes ago with no back pain, and really it is primarily musculoskeletal and not a red flag. I think in a child, to your point, at least from my limited experience, you start to worry. And I think the pain nature, along with how things have progressed, makes me translate this more actually into inflammation. So like, is there an inflammatory syndrome going on? And so when I see the combination of these different aspects of the neuroaxis that are being affected and layer in inflammation, I mean, we can certainly lean on the I made mnemonic and work through that. But I think in addition to the wonderful things you already mentioned, it makes me wonder. It makes me just think through the structures that hurt in the spine or in the CNS. So this includes like the meninges in particular. And so I think start to see what sounds like almost bulbar symptoms and multiple cranial nerves likely being affected, plus back pain, plus this issue. It certainly makes me think of at least some processes causing meningeal irritation. We had a robust negative review system, as you mentioned, which basically, to me, just suggests that maybe there's more of an idiopathic or primary neurologic process that's going on. But nonetheless, I don't want to layer in too much on that or lean into that too much right now. But those are really only my additional thoughts. I think that was a really excellent start. So I'm going to give us some more information.
Oh, cool. You guys are reaching. It's neurological, definitely. So let's move on. I'm going to give you a few more clues. It will be more clear in subsequent explanations. So next, we examined the vitals, and it were within normal limits, and examination of head, neck, and ENT examination. So we found that there was a patient had a very pale palpebral conjunctiva of the bilateral eye. However, a notable point was there was no lymphadenopathy, and I want all the groups to focus on this word, that there was no lymphadenopathy for the first time. And examinations of the cardiovascular system, respiratory system, and GI were also within normal limit. And on neurological assessment, what we found is that the patient had, as I already told, the patient has dysphagia, and the patient this time has a cranial nerve 9 involvement. So the patient had dysphagia, dysarthria, and the nasal intonations. So we found while we're doing the cranial nerve examination. So, and another thing we found was on motor examination of the bilateral lower limbs, we found that the patient had normal bulk of the bilateral lower limb, but however, there was a decreased tone and the power was completely out. It was 0 out of 5, and there were absent deep tendon reflex. However, there was equivocal plantar reflex and normal anal tone. So this was the examination finding on first hand. So basically, it was neurological signs and signs that we were assessing. So this is my second aliquot, guys.
Okay, thanks so much, Ahmed. Austin, are you in a place where you would be able to go first, or do you need me to?
Go ahead. I'm just changing my location.
Okay, excellent. So, we get a really helpful physical exam here. I wish I was as good as Aaron, but I'll do my best to mimic some of his things. But, as far as systemic signs, we see the pale conjunctiva. And, for me as an internist, that sort of translates to potentially anemia. And I don't know if that's just specific to how the patient looks, or if that is a sign that there could be a systemic fingerprint to this illness. So maybe in the labs we'll get more information on that, and I would love to know if there's any paleness anywhere else in the hands and the palmar crease. Is the patient been more fatigued recently? Have they had any dyspnea? What exactly has been going on there? It seems like the rest of the exam overall is benign. The lymphadenopathy in particular, in a young patient otherwise, definitely could think about hematologic malignancies, leukemia, lymphoma, or infection things otherwise. I'll say that our sensitivity for picking up lymphadenopathy on exam, at least for me, is pretty poor. So the presence is pretty specific, but the absence certainly doesn't exclude it. But it is something I'm watching and thinking about as well. And really just sort of diving into the cranial, to the neurologic exam, sorry. So really excellent description of, how the patient is sounding. And it seems like they're having difficulty swallowing as well. But the money here goes to the motor exam for me. So the decreased tone in particular really takes us away from an upper motor neuron pathology, so something that's in a myelopathy or a brain pathology. And the absent deep tendon reflexes are extremely helpful here. And I think this really points us to less so of a muscular problem or a neuromuscular problem, and more so a peripheral nerve issue. And seems to be pretty diffuse. And it seems like we have this both in the limbs and also, our way up into the causing bulbar symptoms as well. And the lack of the normal anal tone as well pushes us away from the spinal cord. And I think I didn't really get a sense of this initially, but going back to the HPI, it seems like this primarily has started in the lower extremities and has worked its way up. And so the ascending nature of this certainly brings to mind things like AIDP or otherwise known as Guillain-Barré syndrome. I'd have to be thinking more about other things as well. I typically don't think of neuromuscular junction pathologies like myasthenia causing decreased reflexes, so that would probably just be a gap in my knowledge. And then the patient, I assume, is from Nepal, and I'm not sure what exposure they had, but anytime I see sort of decreased tone, I always have to think about botulism as well, but it seems in the bulbar symptoms could be suggestive of that, but I feel like the reflex exam is perhaps less so. But that just could be a gap in my able to script as well. But I think really the examination for me is pointing to the peripheral nerve, both the cranial nerves peripherally and in the lower extremities as well. And I think we'll just have to sort of build our potential differential around that. And I think from here, probably investigating the conjunctiva a little bit more and seeing if that sort of translates to anemia and points to a more systemic fingerprint, or if there's something else going on here. And whether or not we just need to sort of get some imaging to get some more information, I think also would be helpful as well. But Austin, I'd love to know what you're thinking about this exam and maybe additional tests that you would be thinking about doing next.
Yeah, no, amazing job. Is my audio a little better now? No.
No, not really.
Sorry. I would say I agree with everything that you were saying. Just to clarify, did the patient have any sensory deficits?
Okay, no.
No, no
His
sensory
system
deficits.
were
Okay,
very
I
intact.
think that's
Yeah.
yeah. So I think that helps us localize a little bit more within the lower motor neuron space. So, I think, could we invoke the muscle as a possibility? Probably less likely given a normal bulk. Usually if we're going to lose reflexes, the muscle issue has gone really, really far. So that seems less likely. I agree, we're probably not in the neuromuscular junction. So we probably have a primary motor neuropathy that's happening, or we're having issues at the sort of the anterior horn cells themselves. But the fact that we're getting issues in what seems like the brainstem along with the distal cord, and we'll have to kind of do more of an exam to invoke if there's issues in between, where we would have to kind of start teasing out. And so as far as like the next steps of what I would do, I think the normal anal tone, just to add, I think fits well also with a peripheral nerve issue as opposed to an issue at the cord in and of itself. Because usually if we're in the cord or we're in that space, then usually we're going to affect bowel or bladder function as well. So as far as what to do next, I would say would I move towards neuroimaging? Would I move towards an LP? I think we're not hearing anything that the patient is having like a headache or anything to suggest we would need that, have contraindications doing the LP. But if we need help sort of localizing the problem more, I suppose we could do an EMG nerve conduction study. But, to me, I'm wondering, what is the LP going to show us? But I'm not sure what Alec has thought on there, but I'll try to work on my mic here in the meantime. So Alec, if you want to comment and then pass back to Alec.
No, I think that was awesome, Austin. And your mic was better when your camera is off. So thanks for doing that. Yeah, I mean, I think I agree if the LP, particularly in a young patient with the current symptoms, I would definitely be looking for. We don't have any clear signs otherwise of immunocompromised condition that would necessarily require us to, image his brain first at the risk of herniation, but it's also not something I'd want to miss and perhaps something to consider. And I don't know, based off the epidemiology in Nepal, if there are certain other things that may require us to do that. And then, as far as like if we do see stuff in the spine, certainly wouldn't be myelopathy, but in the cauda equina, certainly something we could consider as well, and whether or not lower spinal imaging would be useful in the situation. I think probably yes. As far as the order of which, I honestly don't know what I would do. I think the history we have so far in my adult brain is certainly prioritizing, GPS or AIDP, and so seeing that cytoalbuminologic dissociation would be certainly something I would be looking for. But I think I would just want some basic labs to see if there is some systemic fingerprint of the disease that might shift me towards something else. And then I probably would do at least some basic imaging, probably at least of the spine, and then do the LP as well. But I'd love to hear what you were thinking on it.
Okay. This time, you guys are going in the right direction. It's obviously a peripheral neuropathy, and it's motor because there's no sensory involvement. So, regarding and on the background of the rapid progression of the symptoms and rapid motor failure, we came to the working diagnosis of acute flaccid paralysis, and most probably due to Guillain-Barré, as you've already mentioned. So that was our initial diagnosis. So for that, what we did was to confirm it, we sent the stool samples for acute flaccid paralysis surveillance, which is one of the like a routine protocol that we need to send the stool samples for to rule out diseases like poliomyelitis for one of the protocol by WHO. And so we sent the stool samples, and after that, we also did some blood works, and his hemoglobin came out to be 10. However, this total leukocyte counts and the peripheral blood smears, and everything else was normal. And this time we did CSF examination, the lumbar puncture, and the CSF examination showed this classical picture of albuminocytologic dissociation with a protein of around 190 mg per dl and almost no in cells. So there was a negative cytology. So on this background, on the basis of the clinical presentations and all the investigations aligning at the same directions, pointing towards the same direction, we initially believed that this was a classical picture of Guillain-Barré syndrome. So for that, we started the treatment with intravenous immunoglobulin. It was 2 grams per kilogram over 5 days. So, and for the pain, we managed this patient on, we kept this patient on acetaminophen or the ketorolac. So there was a very good response initially. So when we gave the first dose of intravenous immunoglobulin, there was actually a very dramatic improvement. The patient knee reflexes and the lower limb power returned back to almost 3 out of 5. The swallowing was good. The speech was getting better. And up until the 7th day of treatment, the patient had improved power of up to 5 out of 5. However, by the time there was this day 7, the patient started getting worse. So that was that was the thing that happened in the 7th day. What happened on 7th day was this patient, despite having a 5-day treatment of intravenous immunoglobulin, the patient had a severe back pain. We have to manage that with the fentanyl this time. And again, the bilateral lower limb reflexes and the power were completely out. It was 0. And again, this time, the new set of symptoms, the new set of signs arises. That was the patient had a bilateral upper limb weakness, and in the upper limb, the power was 1 out of 5. And the palpebral conjunctiva went completely pale. The hemoglobin was only 6 grams per DL. So for that, we did some blood transfusion. And this time the patient had urinary incontinence. So this were the symptoms that the patient presented with. And on the 7th day, patient developed the symptoms on the 7th day. So we thought that this must be a treatment fluctuant variant of the Guillain-Barré. And again, it started the same intravenous immunoglobulin, IVIG, and the same dose of 6 to 2 grams per kilogram over 5 days. So this was the course on the 7th day. I guess this is my third algorithm.
Okay, wow, what a turn to the case. Seems like Austin lost connection, so he'll try and join. But in the meantime, we'll try and tackle this. So yeah, now it's sort of reflecting on back on the case. So this is a 12-year-old boy with a history of sort of subacute progressive back pain and lower motor, I guess, peripheral nerve, primarily motor weakness and disease, seemingly consistent with Guillain-Barré or AIDP, but has some atypical features the more I think about it. I think initially the back pain, I'm just so used to basically saying that it's noise and not signal in my adult life that I just didn't really focus much on it. And I don't typically associate AIDP causing significant back pain. So I feel like that's something that we need to explain. And the continuing nature of that is interesting. And in addition to that, it seems like the patient was responding appropriately and then all of a sudden didn't. And so I don't know if this is a side effect potentially of the IVIG itself, or the patient was only partially treated with this, or it triggered this, whatever is driving this Guillain-Barré is just really secondary to something else. And the IVIG was treating some of the symptoms, but really not the underlying cause. And that's why we're seeing ongoing deterioration. The anemia is also quite unique. Unless the patient was nutritionally depleted initially, it was just a mild anemia, but just within a week has gone from 10 to 6. So something is happening to the blood. Either the patient is bleeding, and something with the neurologic symptoms to think about is, could the patient be bleeding in the spinal cord itself as a side effect of the lumbar puncture, or there's something else that could be going on, and that's now causing compression and leading to some of the other signs and symptoms that we're having, including with the urinary retention and whatnot. I think the hemoglobin dropping itself, yeah, so blood loss would be one, potentially hemolysis as well. We're not getting another clear signature for that. We don't see significant icterus, or they could have missed that. We don't have any labs, but I would investigate that further. And then to know, sort of get more of a sense as well as what's driving the anemia, sort of iron studies, B12, all that, and to check a smear as well to assess for hemolysis, or, whether there are other cytopenias as well that could point to a more systemic process as well. The initial labs seem to be overall unrevealing, at least that were shared. So I feel like it sounds like AIDP, but there's obviously something odd about this, and the anemia and the back pain have to be explained. So I don't know much about sort of secondary AIDP except from, infections or vaccinations or whatnot. So could this be malignancy associated? Could this be a non-infection beyond polio? Or I don't even know how sensitive the polio tests are. And I know that can cause also anterior horn, and I think sort of spinal cord involvement in general. And I would have to be like using ChatGPT or looking up online about whether there are sort of other infections that can affect both peripheral nerves and then the spinal cord itself, because the urinary retention could certainly point to me that now the spinal cord is involved as well. So I'm just getting a little bit out of my realm, and I would have to be sort of leaning into my neurology colleagues. I'd have to be looking a lot of things up. But I think right now, one, as the patient is neurologically somewhat deteriorating, we need to be sure that the respiratory muscles don't become involved and watch their respiratory status very closely. And then we also really need to investigate this back pain further. So I definitely think dedicated imaging of the spine would be very helpful. Also be good to clarify and repeat your neurologic exam to look for changes. So in addition to now having upper arm weakness, I believe, seeing if there's any sensory changes that have developed. And then looking for blood loss. Like typically people don't drop 6 grams of hemoglobin in their spine. And that would be a little bit atypical. Usually you would be seeing that much hemoglobin loss, or you'd have being vital signs changes. And so just sort of investigating that a little bit further with additional labs and imaging. And then I would be looking up AIDP plus anemia plus back pain and seeing what comes up and sort of making my way from there. But the IVIG in itself, people can have infusion reactions, but this just seems like it's more progression of that initial underlying disease, and things have just gotten worse. So as far as what to do next, probably MRI of the spine for sure. And then definitely working up this anemia a little bit further, looking for any signs of symptoms of bleeding. And then really thinking more about, in a young person like this, what could change all of a sudden. And I would love to know if the patient at some point developed any fevers or any other signs of systemic inflammation, because I am getting that sense here, just given the rapidity and of the worsening. And so definitely activating the IMA mnemonic. Is this infectious? Is this malignant? This is autoimmune. And because of the patient's age, I definitely would be thinking about infections, but I think I'm just not, my own script isn't good enough for infections that can cause flaccid paralysis besides maybe polio and other weird manifestations. And as far as autoimmune diseases, I don't have a great sense of that either. I could think of paraneoplastic phenomenons, and typically in young patients like this, hematologic malignancy, so lymphoma or leukemia in particular. So I definitely would be looking at the smear, looking for blasts, seeing if lymphadenopathy is now present and we didn't notice before, and deciding whether or not other additional imaging would be required. But yeah, I think in summary, definitely want to image the spine a little bit more. Definitely want to repeat my exam, look for any other nuanced changes, be watching the respiratory status very closely, involving my neurology colleagues, and then really diving into this anemia and figuring out, is this a problem with production, or is this a loss, or are the blood cells being destroyed or sequestered? And I think those are things that we're going to have to get more information on. Austin, I'm not sure that are you in a place where you can speak, or you just chatting right now?
No, can you hear me?
Yep.
Okay, yeah, no, I sorry, having internet issues. No, I think everything that you said makes sense. I was just reading the whiteboard, and then from the adult mind, I had been thinking about, Kirtan had taught us about these nodopathies, which sometimes can initially present like AIDP or CIDP, and then don't necessarily have the expected treatment response. But I'm not sure if this class of diseases applies to pediatrics or not. So I agree. I think maybe solving the anemia will help us make diagnostic progress. So yeah, excited to learn more.
Okay. So I'm taking over now. Just to give a clear perspective that this patient did not have any kind of fever, not at all, from the initial first day of visit to ER till this 7th day of admission. The patient has no fever. Patient was completely afebrile. And we also we perform this peripheral blood smear for this rapid loss of hemoglobin, rapid drop in hemoglobin up to 10. It was 10 and it's dropping to 6. So we did some PBS, peripheral blood smear, and it was completely normal. All the cell lineages, all the cell lines were completely normal. So so just to give a background. And this was on the 7th day. On what happened, as you have thought that we probably need to do some MRI of the spine, of the whole spine. So we were thinking about that, but by the time we were planning for the next day, we were planning, on the 7th, I guess it was on the 7th or the 8th day that we were planning for the MRI of the whole back of the whole spine. But what happened on the 8th day was that it was around like 8th to 9th day. What happened was there was another set of signs we encountered. The patient now is developing a left-sided jaw pain, severe jaw pain actually, and it was so severe that the patient that there was loosening of the left lower second molar teeth, and we could easily palpate. Now we could easily palpate some submandibular lymph nodes. They were right from on the right side, right submandibular lymph nodes. They were tender, and it was rapidly increasing in size from the size of a small pea to around size of 2 by 1 centimeter in around like 24 hours. So this was the finding on the 8th and the 9th day. So I guess I'm allowing the more discussion to happen at this point. So back to you.
Oh, thank you so much, Alvin. And just to clarify, how many more aliquots are there before you reveal the diagnosis?
I guess this would be the last one.
Okay, excellent. Austin, you want to tackle this first, or you want me to do it?
Keep leading us, my friend.
Well, I came out the womb first, so I guess I got to keep going first too. Yeah, just very. I'm just really struck by the sort of rapid progression of this case. Literally less than 3 weeks ago, this patient was a normal 12-year-old and now cannot walk, cannot move his arms. And just a week ago had no superficial lymphadenopathy and now has very significant where it's loosening his tooth. So the rapidity of this and the sort of aggressiveness is extremely striking. And I think to have a very aggressive infectious syndrome over 3 weeks without treatment and to not be dead, which would be somewhat uncommon, but that would make me I would just have to really sort of think about infections I would be missing in the absence of fevers, the absence of other systemic signs of infection. Nothing really comes to mind as far as that would support that. But the lymphadenopathy now in the setting of this really makes me think about paraneoplastic phenomenon. And whenever I think about lymphadenopathy in particular, I just definitely think about lymphoma. And the question would be, what type of lymphoma would this be? Actually, there was a great VMR last week about lymphoma, about sort of lymphadenopathy in the jaw that I would think about. And Kirtan and Robbie gave an excellent breakdown about some of the aggressive lymphomas, including Burkitt's, including DLBCL, and including mantle cell as well. So I would definitely be thinking about those in particular. I haven't, again, I don't take care of kids, so I haven't seen lymphoma in a child since medical school, but Burkitt's lymphoma is typically very aggressive and patients usually have other systemic manifestations. So I'm just sort of struck by that. The other one that can always sneak in there, particularly the patient's age, would be Hodgkin's. But I honestly don't really know how to make much progress beyond that. So I think from here, and additionally to stabilizing the patient, and then the anemia on top of this, how does that play in? Certainly, you could have paraneoplastic phenomenon related to an underlying hematologic malignancy or invasion of the bone marrow itself, although we don't have any other cytopenias, at least shared with us to support that also. And so I'm not just getting the sort of autoimmune flavor to this. So I'm definitely prioritizing malignancy, likely a paraneoplastic process. And the back pain certainly also needs to be explained, and hopefully the imaging at some point gets done and sort of can help us with that. But as far as to make additional diagnostic progress, I think tissue is the issue. And I think finally we have some sort of signal of something that we can go after. And I would definitely be trying to get a sample of this lymph node. Sometimes, again, our examination is just not sensitive enough to pick up lymphadenopathy on exam. So sometimes just scanning to see, hey, do they actually have large inchoidal lymph nodes? Or are there other sites in the neck that we can't palpate that might be accessible? At least in your core biopsy, ideally an excisional. But I would at least try to go after that and see what else we could find, and probably send other systemic markers of lymphoma, checking LDH, checking uric acid, and things like that. And as far as what else to do from there, I would also be very curious to know, in addition to the initial LP, if like flow cytometry was ever sent off of it, just to see if like potentially we could have picked up lymphoma there if there was CNS involvement. But I think we just finally have something to grab on, and I'm very overwhelmed by a 12-year-old patient, and this neurologic case as an internist has definitely challenged me a lot. But I'm good at asking other people to get samples of lymph nodes for me, so maybe I'll just continue to lean into that. But Austin, what are you thinking here?
No, amazing thoughts, and I think you like, as you said, they sort of identified a turning point here, and I think, as you alluded to at the very beginning, the absence of lymphadenopathy on exam is not the absence of lymphadenopathy, period. So, always if there's a suspicion, you need to go looking. And I think I kind of liken this syndrome, whenever we're invoking the possibility of like a paraneoplastic phenomenon, to kind of like what I see in the clinic with chronic itching, for example, or other sort of neurologic symptoms like with lymphoma, we think about like burning chest or numb chin syndrome. Sometimes these are sort of like the sentinel events that then later down the line we discover, oh, this was lymphoma, or oh, this was signal to an underlying disease process, and we just needed to give it time to declare itself. Well, how can we improve diagnostically? And I think if we're trying to go through things a bit more, we said, hey, there's some signal of inflammation. Which buckets of inflammation can we work through? I think, as you said, the likelihood of this being infection is at least a typical infection is quite low, given the presentation and the rapidity of the progression. In particular, if this person was having an infection that was causing this, and it wasn't from like a para-infectious process itself, then presumably we would have had systemic symptoms, sepsis or something would have happened in the meantime. And then we sort of basically are left with the autoimmune and the malignant causes. And I'm not familiar enough with the patient's epidemiology to feel confident about these things, but I think between the autoimmune and the malignant buckets, if we're translating what we found in the neck as lymphadenopathy, then I think we're pretty squarely in the malignant category. And at least certainly this is the most morbid thing that we're going to have to exclude. So tissue is the issue at this point, as you said. How can we then incorporate the anemia? I think what would be missed easily on a smear, I think we could easily miss schistocytes for sure. But I think the other thing would be if there is if we're invoking the possibility of a lymphoma, then is there an autoimmune hemolytic anemia? And so I think from that perspective, having some of the other labs to assess for hemolysis, like a haptoglobin, and then the lymphoma detection hormone, LDH, would be nice to have. And then to your point, scrutinizing the fluid that we already obtained from the CSF to see if there's any other signal from me going on. So yeah, I think next steps for me would be sort of imaging to further clarify what's going on in the neck. And if that's amenable for tissue sample, then going for that and then deciding what to do for there. But, unfortunately, I'm really worried about this patient. And despite our best therapies, they're progressing. And so, having a diagnosis and getting it quickly is, I think, really going to be, the most important thing we can do to try to change the trajectory of this patient's course. So, Alma, please teach us what happened.
Bullseye, guys. So tissue is the issue, definitely. So we're reaching there. So as you guys are suggesting that we need to do biopsy, we did the same thing. We did the biopsy of the lymph node from the right submandibular gland, and what we found was that there was on the biopsy we found that it has a lot of medium-sized atypical cells. They were arranged in diffuse patterns. They had pleomorphism, and they were indicating towards Burkitt lymphoma kind of histopathology. And along with that, we did immunohistochemistry, and they were positive for the markers like CMYC, CD3, CD10, 20, 30, 34 with the BCL6, MUM1, SOX11, BCL2, and TDT and Ki67, the proliferation index of 90%. So these were present as immunohistochemistry, and along with that, we performed thinking in mind the Burkitt lymphoma. One of the causative agent of Burkitt lymphoma is obviously, and most of the time, is Epstein-Barr virus. We checked for Epstein-Barr virus, and it was positive. The IgG was positive. There were elevated levels of serum IgG of anti-Epstein-Barr virus titers. And after the biopsy, the immunohistochemistry, and this EVV titer, we performed the imaging with MRI brain and spine, and it showed this T2 high signal in cervical and the dorsal epidural space. So there were mild heterogeneous enhancement. So all in all, they were indicating towards this infective or inflammatory or the metastatic disease. So that was the imaging of MRI, and the PET scan were kind of showing the whole picture of whatever was happening in the lower back pain, the jaw swelling, the loosening of the teeth, the fall in the hemoglobin rapidly. The PET scan showed it all. The PET scan indicated this thing. What PET scan showed was it was metabolic active disease in the meninges, the cervical lymph nodes, the axillary lymph nodes, the internal mammary nodes, the liver, the spleen, kidneys, bone marrow, paranasal, sinus, soft tissue. It was metastatic. It was everywhere. So we were suspecting lymphoproliferative disease from the PET scan, and we did some bone marrow aspiration. They were all consistent with the lymphoma. So those were the investigation that we did, and we came to this diagnosis that the Burkitt lymphoma, the non-Hodgkin lymphoma, it was causing all the problem for this presentation of Guillain-Barré syndrome, which is very, very rare. It's completely because the Guillain-Barré syndrome is mostly seen and is associated with this Hodgkin lymphoma that as you guys have mentioned, but not with the non-Hodgkin lymphoma. So it was very difficult for us to delineate it towards the non-Hodgkin's Burkitt lymphoma. So however, this biopsy and PET scan and everything did the job. So we're treating this patient as a non-Hodgkin lymphoma, the Burkitt lymphoma. So we were using this BNHL protocol with prefaz COP. So COP is cyclophosphamide, the vincristine, also known as oncovine, and the prednisolone. So we are treating this patient in this according to this protocol, and the patient is in the sixth, I guess, he got it yesterday. Yes, is in the sixth cycle. Yeah, all in all, the diagnosis was Burkitt lymphoma, and well done, guys. You are hitting the right point every time on discussion.
Wow, what a case, Ahmed. Thank you so much for sharing. And yeah, I'm just trying to do a cognitive autopsy, and think a little bit more about what happened. And then I think certainly initially the case seemed pretty suggestive of Guillain-Barré and AIDP, and I guess really recognizing the signals that something more sinister was going on with the pale conjunctiva and the associated anemia, and then the back pain in particular. And I guess I would love to know the back pain. I guess overall that was felt to be from spinal cord involvement from the lymphoma. Okay, excellent. Yeah, just extremely humbling.
We have this MRI image that shows the exact location why the back pain was occurring. We do have one that, right,
Yeah, so I for those of us like whose cameras aren't very big, would you mind sort of telling us what the radiology thought of the MRI? Or do you have that information, Ahmed, about what they read the MRI as? I see the arrow here, but the picture is a little bit small, so it's hard for me to take a close look.
Oh, okay. Okay, they were saying that there was like the D2 image had a high signal intensity on the cervical. It was actually the involvement was in the entire spine from the cervical to this lumbar vertebra or lumbar areas. So they were showing this heterogeneous enhancement, which were very mild. They were indicating some kind of metastasis at those points. That's why there is kind of heterogeneous enhancement. Yeah, this is the only information that I have regarding MRI.
No, that's helpful. Thanks so much. And yeah, I just think another signal for sort of something sinister going on here. And yeah, I mean, I think I haven't seen very many patients with Burkitt's lymphoma, but the patients I have seen typically get very ill and have rapid growth of the lymphadenopathy. So I guess that should have been more of a clue to me as well. But just striking how 3 weeks ago the patient was fine, and then all of this progressed. But yeah, thank you so much for sharing the case. And Austin, I'd love to hear your reflections as well.
Yeah, thanks so much for the case. And just to clarify, did we ever get a repeat LP? And if we did that show any cells at that time? Or did it always just continue to show that there was a high protein but normal cells?
Oh, yeah, definitely. We did a repeat LP, and there was no any kind of cells. No. The symptom of GBS, all those albumin-cytologic dissociation, they were not present at the time. The second LP.
Okay, yeah, no, fascinating. I just I'm trying to piece together sort of the lack of, we see that the spine is markedly inflamed in the cord, and probably it's affecting the meninges to be able to cause pain and not just paralysis without pain. So the fact that we don't see any cells, I find striking, and maybe that's a difference in the population that we're seeing, or maybe this is something that we see in patients with this particular diagnosis. But I'm just having a hard time kind of reconciling those things. And at the same time, it seems like this patient has multiple simultaneous neurologic processes that are happening, and some of them are related to sort of infiltration of the cancer itself, it seems like. But the other of them are more of like antibody mediated or paraneoplastic phenomenon. So this in and of itself, I'm guessing that if we looked back and said, okay, what can cause the combination of these things? Because it's hard to invoke that they're explained by one lesion, that maybe the differential diagnosis of that is pretty small, but certainly have a lot of reading to do. And then when we go back to reflect on infection now, like I was thinking to myself, what infections can involve? And, really we're left with the viruses. So I think thinking through the viruses would have been helpful to help us make progress. But really, this is a really humbling case, and how much you guys did such an incredible job arriving at the diagnosis, and hopefully they're doing well and making progress with their chemotherapy. But wow, yeah, thank you so much.
Thank you, guys. Thank you very much for. It was really, really. This. You guys were hitting the right point every time, and it was like, oh wow, you guys are there. So it was exciting for me to like present this. Thank you very much for having me, actually.
Thank you so much for coming, and I really hope that you try to share some more of your cases in the future. And the older the better for me. But thank you again. What an amazing case! What a great job taking care of the patient, and just a lot to learn from this case. And I'll have to do a lot of reading. Yeah, so I'd love to pass it over to Ibrahim now, who will take us away with the teaching points.
Yeah, so thank you, Ahmed, for this amazing case. And thank you to Alec and Austin as well for getting on the diagnosis, even though you guys are internists, but I think you guys did a superb work here. And so for this patient, we started by discussing their presentation, and we tackled their age, we tackled their lower extremity weakness, their constipation, their pale conjunctiva, as well as their lymphadenopathy. And so in a young patient who's presenting with back pain, you can think about it as urgent as you would think of a chest pain in an adult patient. And for the lower extremity weakness, you can basically think about it anatomically. So you can think about the spinal cord, the peripheral nerves, and any concurrent lesions that could be happening in both. And for the constipation, that was a further clue that made us think more about the spinal cord pathology. And so if you have a patient who's a child and they have back pain, and they also have progressive neurological decline, here you should mainly be thinking about inflammation. And so this could be due to meningeal irritation or really any other cause within the eye-made mnemonic. And so within the pale conjunctiva as well, we were wondering if this was anemia per se, if it was a non-specific sign. And typically, if you see pale conjunctiva in a child, you want to inquire for symptoms of anemia just to make sure that this is due to anemia, not due to any other cause. And when it comes to lymphadenopathy in a young patient, you want to think about an infection, but you also want to think about malignancies, including leukemias and lymphomas. And I think Alec and Austin here really did a phenomenal job in helping us localize the patient's presentation. And so after we heard that this patient had absent deep tendon reflexes, we immediately started thinking about the peripheral nerve pathology. And considering that they had both limbs or bilateral involvement, we thought about the diffuse process. And with the decreased tone, this lowered the pretest probability of a spinal cord involvement. And in the constellation of all of these presenting symptoms, you want to mainly think about AIDP or Guillain-Barré syndrome. And in the normal sensation, if a patient has normal sensation, just like our patient did, you want to think about the neuromuscular junction, the muscle itself, but you want to also look at the muscle bulk, and you can also think about the anterior horn cell involvement. For the next steps, we agreed that we would order some neuroimaging as well as an LP to look for albuminocytologic dissociation. And then when we heard that the patient had a rapid drop in their hemoglobin level without an obvious external bleed, we were thinking about an internal bleed, but also hemolysis. In the context of anemia, within the context of malignancy, which we were thinking about here, especially with the back pain, you want to think mainly about DIC. And so you want to look for schistocytes on the peripheral blood smear. And you may also want to consider autoimmune hemolytic anemia in the context of an underlying malignancy. And I think with that, I am done with the teaching points for today. So thank you all for this amazing case.
Awesome job, Ibrahim. Thank you so much. Thanks again to Ahmed. Thanks again to Hemoon for scribing, and thanks to Austin for sort of making his way through clinic with connection issues to tell me out with the case. And yeah, I just wish everyone a great day, and happy CP solving.
Thank you very much.